Welcome everybody. My name is Eric Thomas. I'm the Vice-Chancellor of the University of Bristol, and it's my great pleasure to welcome you all here today. And it's fantastic to see so many of you. When we did our centenary lectures, we would get audiences of this size from Bristol coming in to listen to our lectures, and it just, to me, shows what an engaged, thinking and interested city this is in the issues of the day. So it's fantastic to welcome you here, and I'm sure you're going to have a great evening. It's also a great pleasure to welcome Dame Sally Davies here, the Chief Medical Officer. It's difficult to think of a job more complicated and demanding than the Chief Medical Officer on a day-to-day basis. So it's a great pleasure that she has taken the time to come down here to Bristol to see some of our research and also to give this inaugural Elizabeth Blackwell Public Lecture. Professor Tavern will give you the background to the Elizabeth Blackwell Institute and what we're doing, but it is an absolutely major part of our health research. And it is great that it's happening here in Bristol, which is a city which embraces interdisciplinarity, the breaking down of boundaries, the kind of work that this institute is looking at. We're going to be the world's most connected city at some stage in the not too distant future, and we'll be able to use that as part of the research that this institute is going to do. And it demonstrates our capacity to work closely with very important partners, Bristol Health Partners, our NHS trusts, our City Council, as well as the other main university in the city. So great opportunity for the future for this city. So with those few words, another welcome to Dame Sally and to you, and I do hope you have a most enjoyable evening. Thank you very much.
Thank you very much, Sir Eric. It's great to see so many people here tonight. I'm not surprised given our speaker tonight. I'm absolutely delighted to welcome Dame Sally to Bristol, the City of Bristol and the University of Bristol to give this very important lecture tonight. In fact, I can see a few small seats at the back there, but I believe there's been a black market for tickets, which, considering they're free, is quite interesting. I hope you didn't exchange any money for them. So my name is Jeremy Tavern. I'm the director of the Elizabeth Blackwell Institute, and what the Institute really is all about is about interdisciplinarity. It's about bringing people together in many different disciplines, very widely different disciplines together to do really exciting health research. And I think we've had a very interesting afternoon this afternoon with Dame Sally, looking at some of the fantastic research that goes on here in Bristol, in the City of Bristol and at the university. Enough of that, though. The reason we're here is to hear Dame Sally, but also to celebrate the achievements of Elizabeth Blackwell herself. Now, Elizabeth Blackwell isn't so well known in the City of Bristol. If you go to America, and particularly the East Coast, she's actually remarkably well known. She was born in Bristol in 1821. She left for America at the age of 11 because her father's sugar refining business became bankrupt. And there were also the small matter of the Bristol riots at the time, which meant that the family decided to seek their lives elsewhere. So they emigrated to America, to New York State. And over there, Elizabeth Blackwell decided she wanted to study medicine. But in those days, as a woman, that was not possible. She scrimped and saved and worked hard to get to medical school. She applied to all 26 medical schools, as there were then. And most of them, bar one, refused her entry. Only one, Geneva Medical College in New York State, actually accepted her, and only because the dean there decided that he would put it to a vote of the male medical students whether they would allow her in. And they were quite rebellious, and as a joke, they thought they'd all vote in favor of her entering medical school. So she did. She ended up, in fact, graduating as the very best student in the year, graduated with honors in every subject, and was utterly brilliant. From there, she came back to Europe. She worked briefly with Florence Nightingale, She ended up being the first woman to be entered onto the UK medical register when it was briefly opened. It was quite soon shut to women shortly after that. You can't believe this stuff happens nowadays. But importantly, in 1871, she set up an organization called the National Health Society. And the motto of the National Health Society is prevention is better than cure. And this organization lasted all the way to the year before our very own National Health Service was founded in 1948 by Nye Bevan. And I'm sure this motto, prevention is better than cure, will chime very, very well with Dame Sally and her work. Dame Sally, I don't think you gave a talk in this building in the 1800s, but Elizabeth Blackwell, importantly, gave a talk at a social science congress in a building called the Blind Asylum, which was demolished to give way for the tower that you will have behind you. And she gave a very impassioned talk about education for women in the medical profession at that meeting. And so I think this is a beautifully poignant place for Dame Sally to give the inaugural Elizabeth Blackwell Lecture. Last year, 14 of the Elizabeth Blackwell's descendants came to witness the launch of the Elizabeth Blackwell Institute. And they donated very kindly some money, which I decided should be used to support an annual Elizabeth Blackwell Public Lecture in the fields of public health or experimental medicine. And it would always be given by a woman with a very high profile, and I cannot possibly think of anybody better than Dame Sally to give the first lecture. Over to Dame Sally. Recently voted the 6th most powerful woman in the UK by Woman's Hour on Radio 4. Her CV contains an abundance of extraordinary achievements, any one of which would make you respected and famous. Dame Sally studied medicine at the University of Manchester and then became a hematologist, specializing in sickle cell anemia, and I think you did some early work on the rhesus antigen. After a brief flirtation with lab science, and I think it's fantastic that you did have that flirtation, because I think it tells you a lot about the challenges of biomedical research and translation. Dame Sally went on, in fact, to be the first Director General for Research and Development of the National Institutes for Health Research, which she founded. The NIHR, as it's abbreviated now, has an annual budget of $1 billion and has completely transformed clinical research in the UK and has been very important for us in Bristol, where we've been real beneficiaries of Dame Sally's vision and powers of persuasion. And in creating the NIHR, Dame Sally succeeded where many other powerful people had completely and utterly failed. And recognition for her achievements came in 2009 when she became Dame Commander of the British Empire for services to medicine. In 2011, Dame Sally became the Chief Medical Officer for England, the first woman to hold the post. In this position, she advises UK government on all matters related to public health, and I'm sure wider than that as well. And that includes things like the Ebola outbreak and antibiotic resistance and its threat, which is the subject of tonight's lecture. Dame Sally is a player on the global stage. She plays an important role in the World Health Organization, on their Advisory Committee for Health Research, and this year Dame Sally was elected a Fellow of the Royal Society in recognition for her work, and highest honor we can bestow to scientists in this country. And at the heart of everything Dame Sally does is evidence. She advises based on evidence, and I think that's why she's so powerfully persuasive to government. On the Radio 4 program, Life Scientific, Jim Al-Khalili described you as somebody being a champion for patients and a champion for women, and I think they're both things that Elizabeth Blackwell also fought tirelessly for in the 19th century, and I know Elizabeth Blackwell has been absolutely proud of you giving the inaugural Elizabeth Blackwell Public Lecture. Dame Sally.
Thank you very much. I'm not going to talk about Elizabeth Blackwell because we've heard her history, but of course I did look it up, and I feel in awe of such a wonderful woman born here. I should also say before I start that I'm not going to have much space, so I think I might end up with my notes. There's confetti around me, but never mind. That I have seen some wonderful research here in Bristol, and it's particularly thrilling to see the join-up between the health sector, the health service, and the universities in the plural, and how they're all working together in the interests of patients and the public, in the interests of all of us. That's what we need. I'm getting more interested as I get older. So, what I'm going to talk to you about is something that's become a passion of mine. It's antimicrobial resistance. And this is a deadly reality. So we know that at least 25,000 people per year in Europe die of resistant bacteria, and at least 23,000 deaths in the States. Do you know, that's about the same number as road traffic accidents. People get upset about road traffic accidents. Why are they not getting upset about this, which is going to get worse, whereas road traffic accidents have been coming down? And then if you go to Southeast Asia, 1 child under 5 dies every 5 minutes or more. Children. It's tragic. The other side of this coin is that there are very many people in the developing world who have infections that could be cured by antibiotics, and they're not getting them. The WHO reckons that antibiotics have added, on average, 20 years to our lifespans. At the moment, 7% of people die of infection. Before antibiotics, 43%. So this is really an important issue. Do our antibiotics work? And will they go on working? And actually, we're in a difficult position. So I came across this as an issue. It is going to be confetti, you know. When I wrote my first annual report, one of the pleasures of being Chief Medical Officer is that I'm appointed to be an independent advisor and that I'm expected to write an annual report. So we surveyed my predecessors' annual reports. You notice they're all men, and I'm proud to be the first woman. We surveyed their reports, and what we found was there were 2 bits. There was surveillance about the state of the nation's health, so I do a volume 1 on that, but then there was advocacy about an issue. So for my first advocacy, I chose infection. I thought, this should be safe. It covers community, acute medicine, social care. It covers all of us. Should be safe. I should have known better. I got in the experts to write all the chapters. My role, choose the subject, at least I defined my role. It wasn't the role my predecessors had taken. Get the experts, they will put their names to it. It will be evidence-based. They will write the chapters. I write the policy bit, overlying it. And I'm a hematologist, as you heard. I knew about antimicrobial resistance. For those who wonder why I float between, antimicrobial resistance means resistance of bugs, fungi, viruses, anything that infects us. All of those are a problem. The acute problem is antibiotics, antibacterial. So if I flip between, you at least know where I come from. And I was frankly horrified to find how, since I, in the mid-noughties, had stopped clinical medicine, it had got worse. In fact, I accused all these experts. I said, well, where's your voice? Why haven't you been telling people? And they said, we have. They haven't heard us. So I felt I had to give voice to this problem to government. Sorry, we're going to have to go through this again. I should have put them in a better order. And I started to do just that by demanding that as an issue, it should be put beside pandemic flu and terrorism on the National Strategic Risk Register, which is what's happening. But that drew real attention to it. And as I got more into it, I realized this was not a modern new threat. This was something that we've known since we've known about antibiotics. Indeed, Fleming, who, as you know, was the discoverer of penicillin, actually described antibiotic resistance in his Nobel Prize acceptance speech, saying, it's not difficult to make microbes resistant to penicillin by exposing them to concentrations not sufficient to kill them, and the same thing has happened occasionally in the body. So he described it, and very soon we began to see it. And actually, we went through in the early 20th century a wonderful golden era of antibiotics, where we dropped to that level of infections I told you about. But then trouble started. Because in that golden era, we discovered lots more antibiotics. But look at that discovery void. We've had new antibiotics in recent years, but they were actually reworkings of the old antibiotics. They were not new antibiotics. We've had no real new antibiotics since the late 80s. That's pretty poor, wouldn't you say? I think the whole of the scientific and medical community have been caught napping. So, it's not surprising that the Lancet and myself and a number of other people are starting to stand up and say, we are at the dawn of a post-antibiotic era. And do you know what that means? We use antibiotics to cover operations as simple as cesarean sections, hip replacements, all bowel surgery. If you have diabetes, you're more prone to infections. If you have a renal transplant, a bone marrow transplant, or indeed heavy chemotherapy or radiotherapy, you need antibiotics or you'll die. I could imagine a day when I was told, so you have cancer, and we could treat it, but that'll drop your white count, so you're sure to get an infection, and it's odds on we won't be able to treat your infection. And I'm going to say, so why would I want the horrible cancer treatment if I'm going to die of infection? Why don't I just have palliation and live it out? I can envisage that happening if we don't get on top of this. We're going to get back to that pre-antibiotic level. And it's not always because people are misbehaving with antibiotics. I'm going to come to misbehavior. So this is about gonorrhea. And the lines you need to look at are the top lines, particularly that solid orange line, ceftriaxone. We now have gonorrhea looked after in this country in specialist clinics, proper guidelines, people adhere to them. Yet, 2% of infections are untreatable. Urethritis, rather painful. Arthritis, very nasty. And so when I talk about this, I know what people think. They think, oh yes, but that's a sexually transmitted disease. I won't get it. Actually, these are rampant in society. And if they're untreatable, they'll be even more rampant. This is a worry to me and should be to everyone. So let's just look at where we've got problems. We've got problems in humans. Everywhere we look, it's not just in the health system. Aquaculture, that's growing fish to people like me. I'll show you data about how antibiotics used to be, and still are around much of the world, overused in fish farming. And then, of course, you've got sewage. Did you know that antibiotics are not broken down by the body? So all the antibiotics we eat, or for that matter, animals or fish, just gets peed out into the environment and sits there. It's quite horrendous the more you learn about it. So there are antibiotic-resistant organisms all over the place. They get into wildlife. They get into, isn't this a lovely expression, pets, companion animals. Food animals. Over 70% of antibiotics in the world are used to feed to animals instead of doing good hygiene, because it's much cheaper. Growth promotion. Horrible thought. So you know, when you go to the States and you eat all those wonderful steaks, I have to say, I now go, ugh, they're full of antibiotics. Not very nice. And then, if you think about how the food chain, it's really rather messy and horrible, let alone the rest of it. So it's a very complex epidemiology. And, you know, I'm told that antibiotics have even gone into the paint on warships to stop barnacles sticking. When I told the science ministers of the G7 that about 18 months ago, that was when they sat up. Government responds to battleships, clearly. But this is very worrying. What I haven't talked to you about is how it spreads. And it's very interesting. Bacteria multiply every 20 minutes. So clearly, if you have a natural mutation to give you better survival, that's Darwinian, then it will multiply rather fast. But a lot of the resistance is held in little circles of DNA that they can inject through a kind of, well, it looks a bit like a penis, but I think it's called a proboscis, into another bug, and they shoot these circles of DNA with resistance into other bugs, so they can spread it in all sorts of ways. It's not just through other generations. In fact, one lovely study done by the Swedes, who are very active in this field, they looked at a tribe of young men going abroad for holidays, found no antimicrobial resistance in their feces, that is in the bugs in their feces. A quarter of them had it when they came back from their travels. It travels around. And we do, as I've said, rely on antimicrobials. Look at the number of courses of antibiotics prescribed by GPs. Look at the number of days, 27.5 million working days lost, there's the confetti, in the UK. And the other thing you have to realize is we're talking at one moment about our nation, at the rest about the globe. Over half of antibiotics just bought over the counter. Horrific. And there are great variations in use. I'm learning a lot about this now. But look at this from the highest in Newcastle, 8.4%, to less than 50% of that prescription level in Camden. Now, I can argue that there's health inequalities and all sorts of reasons for some difference, but more than double the difference? What's going on there? There's some overprescription. But I do want to point out we're not different from anywhere else. Just look at the states and how the two coasts have the lowest prescription rate. You might have expected that, whereas the middle of the country has the highest prescription rates. This is just the norm across the world, that there are variations and we need to get it sorted out. So, we've got to look at this as a globe, strengthen international collaboration, and that immediately gets difficult because people are talking about, you mean you're going to make us prescribe our drugs? No, but we do have to find ways to look after the drugs, protect what we've got while we do something for new ones. And we need to work with those countries through governmental and non-governmental organizations, the regulatory bodies and lots of others to get the changes we need. And this is extraordinarily difficult. Let me show you an example. So these are both carbapenem-resistant Klebsiella pneumoniae, which are gram-negative bugs, which are the big problem. So if you take the one that started in North Carolina, within 5 years, it had spread to a number of countries, the orange network lines you can see. The New Delhi metalloproteinase 1, NDM1, was found in 2008, and by 2010 was actually in 16 other countries. It's a great misfortune it was called New Delhi because they get very upset. You're anti-India. No, we're talking about the problems and what's going on. And these now are terribly difficult to treat. I'm not the first person to call time on this. The World Economic Forum in Davos put a global risk picture up in 2013, talking about the costs of AMR. We've done some work showing the societal costs are probably at least 10 billion a year in our country. The costs in the States have been modelled at around 30 billion a year. Russia, unnecessary antibiotics. It's not just Russia, it's all over the world. I'm horrified by this bit, that if you go and test seawater in the Antarctic or around Japan, so I bet if we test it elsewhere, there are resistant bugs in the water. So what do we have to do to cope with this? Well, we've got to conserve what we've got. And a lot of people call this antibiotic stewardship. Doesn't matter how you frame it. But we've also got to work on what we've kind of called the One Health approach. We've got to think about it for humans, but everybody else too. That's animals, fish, and the rest. And that means we really need to have guidelines across the whole system. I am pleased to tell you the EU is very strong on this and insists that they're not used for growth promotion, but we do have big problems still in America. And then you get African countries saying, well, if America, a rich country, won't behave, why should we? So the problems of climate change play out again here. And then, of course, I think that in the developed world, because we've had antibiotics and we're so used to cleanliness, we've lost some of our concepts of hygiene. I mean, are children taught enough to wash their hands with soap and water? Is infection control always good enough at home and in the NHS, at every bit of the NHS and everything? And we do need to make sure that people, use infection control and proper hygiene measures at all times. I thought you'd like this example. These are individuals hand vaccinating fish with mixed vaccines. And if you look at the impact in Norway, you can see the use of antibiotics in orange coming down as vaccination goes up. Scotland's done the same. And in fact, I do have a slide of Scotland that sometimes I show because they got very upset with me that I was using the Norwegian slide. But I do still buy Scottish smoked salmon as the best. So you would say the solution lies in a new golden age of antibiotics, and of course it does. But what's the big challenge of economics? We don't pay much for antibiotics, and we don't use them much, really. I mean, it may be 37.5 billion prescriptions or million prescriptions, but that's still only one course maximum a year for most people, and not even that. Whereas a blood pressure treatment, a diabetes treatment, a statin for cholesterol, every day for years. The economics are not for it. We've got a challenge of geography, and I've talked a bit about that, but you would not believe how poor surveillance is across the world. In fact, in this country, I called a meeting on Tuesday of the clinical leaders of the nation. It's the first time I've done it, and they all turned up. The boss of the BMA, the bosses of the Royal Colleges, the national clinical directors. And I said, so what are you going to do? And they are going to do something. But what they wanted was the data. And do you know, we don't have all the data at hospital level, let alone drilling down to the wards and the specialties. We're going to have to do something. Our own surveillance is not good enough. Containment is very, very difficult. And we've got to do something. And we've started work intergovernmentally. There's a scientific challenge. Those who are better placed than me can tell you that the basic research is really difficult. But of course, if we do research to get rapid diagnostics, we can cut the use of antibiotics, because think of the number of children with a sore throat that get antibiotics when it was a virus and they didn't need it. But somehow they were impossible to get out of our rooms. non-human use of antimicrobials. We don't fully understand the link, but we do know that there's a risk and that this is not good, and there is some data. So we need to continue working. Can you see it say Longitude Prize? Yes. Many of you will have voted for the Longitude Prize last summer, and thank you for those who did, because over 100,000 votes and a rapid diagnostic for, to help with antibiotic conservation and antibiotic resistance was voted by the British public to be the subject of the Longitude Prize, which was launched with the details last week on European Antibiotic Awareness Day. One thing I do want to highlight is how this government and our public have taken this issue to their hearts and are making it a high priority. Indeed, we're also doing some extra terrestrial research. So this is antibiotic effectiveness in space using E. coli cultures. I just thought you'd like to see that. What have we done then? Well, this government has worked across the whole of government to produce a 5-year antimicrobial strategy that is much more robust and strategic than they had originally written. They beefed it up as a result of my annual report. The two other things I want to pick out on this slide is we got through a WHO resolution through the World Health Assembly last year that the WHO should publish a global action plan. And normally when a CMO takes a resolution to the World Health Organization, 1 or 2 countries sign up. Our Foreign Office did the diplomacy. They were fantastic. Over 60 countries signed up. They're now doing the diplomacy across the world, not just in Geneva with those delegations, but in capital cities to make sure that the global action plan goes through. And it's a good global action plan. I chair the WHO Strategic and Technical Advisory Group. They were clever enough to realize it was better to have me in the tent rather than outside. Meanwhile, our Prime Minister has commissioned an independent review to examine the economic issues associated with developing new antibiotics, treatments and everything, from Jim O'Neill, who's just started, formal launch in a couple of weeks. He was the chief economist at Goldman Sachs. And so this is a bit like the Stern review in climate change that really, because of doing it from an economic perspective, got it on the map globally. So we're doing that. And I think that'll work well. We can make a difference. What you see here are in green are Clostridium difficile cases and in blue MRSA cases. And because we had targets and a big focus, we dropped it. No government likes targets in case they miss them, but it is important to see that when we put our minds to it in the NHS, we can make a difference. We're making a difference in research. The Medical Research Council leads a research funders forum. We've all been doing calls for research. There's international research collaboration, and I was sent the other day the work that the BBSRC is doing. The EPSRC are funding work in it too. They've got a £5 million call out at the moment for engineers and physical scientists. NIHR is scoping research questions on environment and AMR. So the whole of the government funding system and the Wellcome Trust are looking to take this forwards. We will crack this, but it needs everyone in this room and everyone to help. Clearly, a big issue is awareness. You will have noticed, I hope, that it was European Antibiotic Awareness Day last week, and there was a lot of work around that, and that was the day last Tuesday, I think the 18th, when the Longitude Prize was launched. So that helps, and indeed, European Antibiotic Awareness Day is fast becoming a world one. I've mentioned the World Health Organization resolution, so I will just say, wish us well on the diplomacy as we go forward. We know which countries are going to be difficult. We know why they're going to be difficult, and we have to get this right. what can you do? Well, you could go and do as I did, put into Google Antibiotic Guardian and PHE, short for Public Health England, and you get to watch a really nice short film. It's about 10 minutes about antibiotic resistance, and then you can sign up as an antibiotic guardian. So please do that. You can talk about this to everyone, raise awareness, raise concern. More importantly, you can begin to say, do I really need the antibiotics? Is this, got worse, is this an infection that needs antibiotics? Because it's very important that we conserve what we've got. And I know that for doctors, it's very difficult. You're thinking about an individual patient in front of you and you want the best for that patient, and we are not trained as clinicians looking after patients to think of the population. But there's a lot of very good work being led here in Bristol to help GPs decide whether the patient, the child, is likely to need antibiotics. And we need to spread the word so that people are more careful. Because I'd prefer that a child waits a bit, and when that child has grown up and developed some nasty disease, there are antibiotics that work for that person, then we dish out antibiotics and we have nothing later on when they're grown up and they need them. We really need to start that debate everywhere, and all of you can play a big role in it. The reason I'm here is because I care about this. I really want us all to face it, to focus on it, and do something about it. I've even written the book with some colleagues, and I can tell you that and ask you to buy it. It's on Kindle because I don't take the royalties. I've even done a TED talk. It was pretty scary, actually. It's one of the more scary things I've done in the Royal Albert Hall, absolutely booked out, solid, crowded. And they won't let you have notes, and you'll have noticed. I quite like having notes. But we all have a responsibility in this. The government's taking it very seriously. Slightly to my surprise, but my great pleasure, our Prime Minister insisted that antimicrobial resistance was in the G20 communique out of Brisbane. It's only when we have the global leadership saying this matters, so they make it a priority and the money's there for research and for the education and everything, and that meets the patients and the public saying, do be careful, I want a future, maybe I don't need it, so that the NHS in the middle can do the right thing, that we will get this to work for us in the future. So, thank you for coming to listen to me. Each of you has a responsibility in this. Each of you can play a positive role by your future behaviours and how you influence other people. So you may have thought you came here for an easy ride and to be entertained. As your Chief Medical Officer, I have to say, there is no free ride. This is no longer the golden era of antibiotics. This is when we, as a public, have to face up to our responsibilities and get it right. In finishing, I just want to say I am extraordinarily honoured to be the inaugural lecturer for this series. I must say that she sounds the most wonderful woman, and I think we all wish we had met her. And so I thank you for the honour that you've done me in letting me give this lecture, and I hope that I have done her memory justice. And now I have read up on her, I'm going to use her, and therefore Bristol, in some of my talks elsewhere. Thank you so much. Never mind.
Well, that was absolutely fantastic, and I know that Elizabeth Blackwell would have loved every moment of that and stood behind every word that you said. So thank you very much, Dame Sally. I hope you're happy to address a few questions. If there are any questions from the floor, then Dame Sally is very happy to answer them for a few minutes. If you want to ask a question, put your hand up, and a microphone will come to you as quickly as possible for you to speak into so that everybody can hear the question. First question, right down.
Dame Sally, I was just wondering if you have a compact with the Chief Veterinary Officer as well, given the amount of antibiotics that are used in the farms all over Europe and beyond.
Yes, we work quite closely together. In fact, last Friday morning, I went to the well, basically the vet show for the year and spoke. And I realized what a good compact we have when he smiled as they tried to beat me up. But you will have recognized that I'm fairly robust, and I responded. Our vets are pretty good. You know, compare ours. Northern Europe's are pretty good, probably the best in the world. The further north you go, the fewer antibiotics used. So, to be as good as Scandinavia, but we're well on the way. And the chief vet did quite a lot of things for European Antibiotic Awareness Day. But we can always do more, Nigel.
Tim Gallagher down here.
Can I ask you, if we bring a new antibiotic, a new class of antibiotics to the market, how will we actually manage their use, and how will we ensure a company is incentivized to do that expensive drug discovery?
So, for the non-cognoscenti, I've begun to understand what we've just been asked. The first is it costs about £1 billion to produce a new drug, and antibiotics may be even more expensive because of a large failure. The second is the public health issue that, as I keep saying to companies, just produce a few antibiotics. And by the way, I, as Chief Medical Officer, will lock them up because we want to use them to save lives, not just to treat people. We want to save lives where they have to be used. So where's the market and the profit? And that is the conundrum. And there are various ways through that: advanced purchase commitments, paying a lump sum so that volume doesn't matter. But how do you do that globally? And do we actually develop them through public-private partnerships? And that's exactly the set of issues that Jim O'Neill has to grapple with, and then persuade the World Bank and ministers, particularly in the BRICS and the MINTS countries, to come in and support. And as he was the one that coined those terms, BRICS and MINTS, he knows them all, and I'm very optimistic. But it is a problem.
Dame Sally, thank you so much for your talk. Alistair Hay, I'm a professor here. We met earlier today, and I'm a GP. Now, clearly, everyone in the room is now a convert, and is not going to unreasonably expect an antibiotic from their GP. But I just wonder how realistic it is for our patients to be altruistic and take the wider perspective and put off their desire for an antibiotic, which they need badly. Many of them are under huge pressures to manage families, work commitments. They've got international presentations to give and so on and so forth. They've got all the best reasons in the world, which I, as a GP, find extremely difficult to dissuade them. I just wonder how we can get this message out that the altruistic population approach is going to be more important than my individual needs today, here and now.
So just start by standing up, Alistair. You have here someone I'm very proud of. He's one of our NIHR professors. He works here in Bristol on antibiotic resistance, among other things, and he's wonderful. Thanks. He does fantastic work, and he probably knows the answer better than I do. So often happens, doesn't it? And I think it is. I absolutely recognise, Alistair, that tension. And that's why I talk about it. But if we don't educate people and start getting them, I've got the same with flu vaccination, actually. We want small children, 2, 3, and 4-year-olds vaccinated to help protect them, but actually, much more importantly, to protect their grannies. Somehow, because they're super spreaders, somehow we've got to kind of get people to understand it isn't just altruism, that if they need antibiotics, they should have them. So that's the first thing. How do we define who needs them and make sure they get them? I'm not advocating people who need them not getting them. So how do we define that better? And how do we persuade people who don't need them that actually they shouldn't have them? And you've done some nice work on helping define which. Paul Little's work on delayed prescriptions has shown good promise. But I think if we start to relate it to their own families, you know, if I give little Bloggins an antibiotic, which I don't believe is needed, remember grandpa who's having cancer at who's got cancer at the moment, we may find it more difficult. And I think we're going to have to start to tell the stories within families to get them to start to think about the trade-offs. But no GP is going to be happy doing that without more help of the tool you've got, rapid diagnostics and things as well. So it's going to be a long journey. But we've got to start telling those stories so people get the broader picture rather than just the me, me, me. It's absolutely the wrong time, isn't it? We've got a totally different society which has shifted from altruism in general into a much more person-centered me, me, and I have rights and things. It's a difficult one.
A long, long time ago in a land far, far away, I was a general practitioner for 2 years.
I didn't know that.
In Australia, and I recognized the pressures that doctors are under when someone comes in with a young child and the child's got a sore throat and, you know, why aren't you giving me an antibiotic? What I was just thinking as you went through your talk, what I would have loved then was something that someone could have spat upon or something like that, and I could have said, look, it's not bacterial, it's a virus. So I can confidently look you in the eye and say, actually, me prescribing antibiotics to you is not going to help this in any way whatsoever. Now, I'm miles away from that now, Sally, so I just wondered, how are we near that sort of potential technology?
Well, I think it's in our grasp, but we haven't got it yet. I started life as a paediatrician, so I have faced this too. And that's why I was thrilled that we managed to win the Longitude Prize and get the Longitude Prize faced at a rapid diagnostic. And the one I really want to start with is throat infections, because that has an upper respiratory tract infections. That has to be the biggest abuse of antibiotics. And then we could go on to others. And I'm told there are technologies that could be used within our grasp, but not here. There was a lady over there.
There was a lady down here. There we are.
Ah.
Yeah,
and then one down there in purple, I think.
Okay.
But I'm looking into the lights.
I was just wondering, you said that there weren't very many people working on antibiotic, like finding new ones. Are there many people working on it at all? And if so, are we expecting to engineer them, or are we just hoping to stumble across them by serendipity?
There aren't many working on it because I think we'd got lulled by that golden age into, hey, this is fine, we can do it. And I think it's crept up on people. It's a bit like the lobster. If you heat it up slowly, it's happy and it doesn't notice what's happening. And I think that's what's happened. And it's fascinating, now I've raised it up over the last 18 months, how money is beginning to pour into this area. A couple of pharma are still active in this field, but they say it's more difficult than most other areas, but all the other pharmas have stopped. However, that isn't the end of the story. I was invited to a European meeting, which they set up because of my call to action, of basic scientists. And the Germans have got an institute that is screening insects for antibacterial compounds. And if you think about it, which I hadn't until I listened to that, insects live with all these bugs too, and most of them live perfectly happily. So they have natural antibiotics. And there are vast numbers of insect types, which I hadn't quite realised. So they're going through screening insects and finding natural products that may turn out to be effective antibiotics. There are other people who are screening plants for them, actinomyces in Newcastle, and then there are people trying to synthesize molecules. So I think every approach will need to be tried, but I was very taken with the insect approach.
There was one question just here, and then we'll go over here.
Thank you. I was just wondering what your view is on the use of prophylactic antibiotics, particularly for routine surgery, especially in patients who aren't necessarily at high risk of infection. Obviously, the use of prophylactic antibiotics would greatly lead to the resistance.
So I had prophylactic antibiotics for a caesarean section. I think if they're properly used, we have the evidence that they reduce post-operative infection. But it is about using them properly, giving them at the right moment, not too early, not too late, and in the right dose. And I was horrified at this meeting of clinical leaders I was talking about to hear two anaesthetists debating how often antibiotics were given at the correct time and how more often they were given at the wrong time. So that I'm not against prophylaxis. If we've got the evidence that it works, we should do it, but then do it properly.
Question over there.
Thank you for your talk. Back to the insects. The insects obviously contain everything within them to cure themselves, and to a certain extent we do too. So the altruistic message that perhaps we shouldn't be feeding our kids antibiotics when they go to the GP, maybe also alongside a message of improving health by a variety of methods, whether that's washing hands, whether that's improving feeding, whether that's improving social living conditions, all the things that we did in the 1900s in Victorian times. You know, we should also be doing that, because that will reduce the need for antibiotics. And if we can do that alongside it, surely it'll be more effective.
Absolutely. The better we can keep people well, the better their immune systems, and hygiene and sanitation are central to all of that. And I'm delighted that the new Prime Minister in India, Prime Minister Modi, has as one of his objectives flushing loos across the country, because they, in India and China, are abusing antibiotics dramatically. Once they've got good hygiene in place, they will begin to have a system where they can do something about it.
There's a question just over here somewhere.
I'd like to push back a little bit on the assumption that there are antibiotics out there in plenty to be found. We still make electricity by boiling water to make steam. We haven't found a different way of doing it. Are we ever going to find all the antibiotics we need?
Well, we won't until we put enough money into it and enough scientists on it, and that's steadily going up. I am told by the experts that this is crackable, but the reason I'm making a noise now is it will take at least 10 years to get something into the clinic, so we'd better start now or we're seriously sunk.
Down here. I think we've probably got time for two more questions, if we take these two in the middle, hopefully.
I understand your argument about conservation, but if 70 to 80% of antibiotics are being used for industrial meat production, and the long-term consequences that that has for the food chain as a whole, and most of us are eating more meat because it's getting cheaper because of the way that it's being produced, how do you tackle that? Because that's the biggest piece of this whole problem, and I don't share your complacency that this is only about American meat. We're seeing exactly the same processes in Hungary, Poland, and Romania. So how do you tackle that?
I don't think I'm complacent about any of this. I spend my life trying to get people to take it seriously. Well, if you asked some very senior people in America, they would say to you, there's very limited evidence that it's their antibiotic overuse in animals is contributing to resistance. But there is some evidence, and actually, as a world of researchers, we haven't gone looking much for the evidence. And it seems to me that we owe it to ourselves, the public, that we do look and see how big the issue is in animals. And I am always clear, at the moment we know that the biggest driver is misuse in humans. But I'm still very unhappy about that 70% use. In fact, in Britain, I've just been told the latest data, it's 50% human, 50% animal, so we're not as bad. But the point I was making was, I believe there is a link because there's some evidence. I believe we shouldn't overuse antibiotics anyway while we do more research, and that America is a major leader in this world, and that other countries who are not as rich say, if they won't do it, why should we? And actually, what we're trying in this country at the moment, we're not too bad on AMR. Most of our patients are all right. It's to get our house in order to protect our public. But even as important is so that we can say to the rest of the world, we're taking these actions, join us in this. Because why would the Commonwealth join us if we won't do it?
We may have time for, was there one more question here? Just very quick question. And
I was just wondering if you have a trajectory for how much reduction in use you would expect to see to feel confident that the antibiotics we have are going to continue to be effective.
Oh, that's an interesting one. No, I haven't worked out a trajectory because some of it is about what we bring in from abroad as well. You will have seen stories of both health tourism, but even more sadly of people who've gone abroad and become sick. One patient had dreadful scalds and then comes back post-treatment in India or somewhere, absolutely riddled with nasty bugs that then get into our system. And we do have them in the system. We have, in Britain, okay at the moment in our intensive care units. Italy has at least 20% of its bone marrow transplant units closed at the moment because of antimicrobial resistance. I mean, this is beginning to hit the developed countries of Europe. So I can ask someone if they can model it, but I think it goes in bumps, but it's progressively upwards, sadly.
Fantastic. I'm sorry, but we've run out of time. It's a fantastic set of questions. Thank you very much for your very lucid and clear answers and for such a wonderful lecture. What we would like to do now, if you don't mind, is present you with a plate to commemorate this occasion. It's inscribed with the details, and to thank you very much indeed for coming and giving the inaugural Elizabeth Blackwell Lecture. I'm absolutely certain Elizabeth would have been gripped by it. Thank you very much. Now, I don't normally watch the Antiques Roadshow, but I did happen to see a little bit of it on Sunday night, and somebody who won Mastermind a few years ago ended up on the show having his Mastermind trophy valued by Antiques Roadshow. So I expect to see you there in a few years' time having this valued. Dame Sally, thank you very much indeed.
Thank you. It's Bristol Blue.
It is Bristol Blue.
I love Bristol.
Thank you very much for coming, everybody. There is some wine outside for you to enjoy and to meet and to network, and please enjoy that. And again, thanks to Dame Sally.